Thank you so much. My name is Tina Bales. I'm an attending physician at Children's Hospital of Philadelphia, and I am thrilled to be here today, and especially thrilled to see old faces and new faces. I can't believe how quickly your children grow up, and it always makes me happy to see the kids. So thank you. I'm going to talk today about bone health and Alagille syndrome. And I always like to start with the patient. For me, that's really what inspires me, motivates me, and I think really is what drives our research efforts. It really always comes back to the patient. And so I'd like to just talk to you for a few minutes about a child that I met. This was really the first child I ever met with Alagille syndrome years ago. He is a 5-year-old little boy who had really almost all of the characteristic features of Alagille syndrome that we read about in the textbooks and talk about in the lecture. And the folks ahead of me have, of course, gone through all of these features. But really what struck me about him was that when I met him, he came to me in a wagon, and his lower leg was casted. And that was not something that I had read about as being associated with Alagille syndrome. And interestingly, when I talked with his mother, she told me that this was a pattern. And if you look at the history here, you can see that at age 3, he had stress fractures of both the right and lower leg bones, and what we call a buckle fracture, where the leg sort of just bends on the right tibia, which is one of the lower leg bones. And then at 4, he had another fracture of the left tibia, and this really healed with a deformity in the bone. And then at age 5, he presented with a recurrent fracture of that left tibia, and that was how I found him. And then really interestingly, a few weeks later, I saw another child, and he looked almost exactly the same way. So this sounds like the first little boy I told you about, but yet it's an entirely different child, and you can see the left lower leg is deformed. So that really got my interest in bones and Alagille syndrome. And I'd like to just sort of talk to you about a few different things. I'm going to start with some very basics about the skeleton, bone growth in childhood, requirements for healthy bones, and how we measure bone health in children. And then I'm going to talk with you about what we know about Alagille syndrome in terms of weak bones and the data that we've begun to accumulate on fractures in patients with Alagille syndrome. I'll also talk to you about possible reasons for this, ongoing research, and then finally, what can we do to prevent these problems in your children. So just some basics. What does the skeleton do? It supports us. It allows us to stand up straight if we choose to do so. We also find that it protects our organs. So thank goodness we have a rib cage to protect our heart, our lungs, and our vital organs. And then finally, it's a very important reservoir for minerals such as calcium and phosphorus. This is a graph that looks complicated, but I think it's really just helpful to look at one area of this curve here, which I'm not sure how to use this. So, there we go. So you can see this is the area that we focus on in children. You can see this massive increase in bone mass as children age. And then by the time they reach the age of a lot of the young children's parents in this room, you're getting what you call peak bone mass at this point. So your bone mass is as good as it's going to get. And then by the time you're 45, like me, you're a goner. You're in the goner phase. And then when you get to Dr. Bacoli, like it's over. So what do we need to do to maximize this process? How do we make this a child as healthy as possible in terms of the skeletal development? So a lot of this comes down to nutrition. These are just some guidelines. We can make these slides available to you so you can get a sense of what your child might need, but your child needs calcium, and those requirements are going to vary with the child's age, and there are daily recommended intakes that we have. Interestingly, children with Alagille syndrome often need much higher amounts of these things to actually achieve the levels that we need them to achieve. So these are great starting points, and certainly kids need these, but most of your kids will need beyond this. How do we get calcium? Our mothers always told us that we have to drink lots of milk, so dairy products. There are, interestingly, lots of fortified foods out there, so if your child hates drinking milk, you can buy orange juice and waffles that are fortified with calcium. Other foods, broccoli, salmon, sardines, a little harder to get in, but look for the orange juice and the waffles. Vitamin D is critical to bone health. It enhances the intestinal absorption of both calcium and phosphorus, and it promotes the release of calcium from the bone into the bloodstream. It is found in very few foods naturally, and interestingly, most of us make vitamin D from exposure to sunlight. So while we definitely encourage you to use sunscreen, a little tiny bit of sun goes a long way in helping your body to have enough vitamin D. So again, here are some of the requirements for vitamin D, and as time has gone on, even since I was a medical student, we know that people actually need more vitamin D than we anticipated years ago. Food sources of vitamin D, again, your mother told you to drink your milk, but if you look at this slide, you can see that fish is actually one of the best sources of vitamin D. All the oily fishes like salmon, cod, sardines are filled with vitamin D, so if you're lucky enough to get your child to eat these, that's fabulous. There are other important vitamins and minerals, and I think these are important for your doctor to monitor. Vitamin K is helpful in collagen formation. Magnesium is critical for bone health, zinc, and then finally vitamin C. So it's not just all about calcium and vitamin D. Exercise is also critical, and fortunately, if children feel good, they do like to do physical activity. Weight-bearing exercise in particular includes any activity in which your feet and legs are carrying your own weight. And I've listed out some examples, but again, if we can keep kids feeling good, usually we don't have to do a lot of pushing to get this accomplished in the toddler years. So how do we measure bone health in children? There are certainly a lot of tests that we can do to measure the levels of these vitamins and minerals that I talked about, and having a physician who understands the importance of this and really measures these levels carefully is critical. Sorry, I'm having a hard time advancing here. Oh, there we go. Okay. So another technique that we use is radiologic techniques. And some people might ask, well, can we just take a simple x-ray and look at an x-ray and see whether a child has bone demineralization? And you can in the extreme forms, but one of the more sensitive measures is something called a DEXA scan. And if any of you have heard of DEXA scans, most of it is in relation to your 85-year-old grandmother who gets her DEXA scan to look for osteoporosis. This is what a DEXA scanner looks like. It's not really a scary process. It's a little bit like an x-ray, and the child can actually just lie on the table and we take some pictures. So there are centers that have DEXA scanners calibrated for children, and it's important to have the DEXA done at one of these centers. The reason for that is that the scanners are calibrated to make separate measurements for the spine and the whole body, and they report scores differently rather than taking an average for all people as we do in adults and we sort of average everybody out. These scanners are calibrated so that you can look at age and also weight and height as factors that you can use to adjust, and this helps us to be much more accurate in our determination of what the bone density is. So what do we know about bone health and fractures in children with Alagille syndrome? So back in the late 90s, there really wasn't much known at all, and really much less than we know today. I think that what we knew at that point was as much as I knew when I met my first patient, and that was that there were case reports of children who had either severe post-fracture deformities or had seemed to experience fractures at perhaps a higher rate than other healthy children, but there was no data to really support this. So sometime in the early 2000s at CHOP, some folks got together and decided that we should really take a look at this and try to measure what the bone density is in our children with Alagille syndrome related to healthy children. So they looked at 31 children with Alagille syndrome and 80 healthy children and did growth measurements, DEXA scans, and then also looked at how those children were processing fat and how much of that fat that they were taking in was actually not being absorbed well. What they found was that Alagille syndrome and healthy children in that group were similar in age and pubertal status. So there were no significant differences between the children at that level. But what they found was that the children were very small for their age, and they had decreased whole body bone area and bone mineral content for their age, even after we corrected for the height on our sort of super duper pediatric DEXA scanner. And we also found that there was an association between poor bone mineralization and fat malabsorption. So that kind of brings me to my question when I started my fellowship was, well, does that decrease in bone mineral content, bone mineral density, actually translate into more fractures in children? So we looked at this phenomenon in our patients, and interestingly, years before I started, one of my colleagues had mailed some surveys out looking at growth in children with Alagille syndrome. So this was not a survey done to look specifically at bone health, but it asked a few questions about bone fractures that we then capitalized on to sort of find a group of children that we could look at. So they had mailed 402 patient family surveys out, and we reviewed those surveys to identify those patients with a positive history of fracture. And then a few of you are in the audience and you got a phone call from me, and I reviewed all of the records that we could get our hands on and talked with parents over their phone about their recollection of what had happened. So all told, we got 42 surveys returned. So not a great percentage, but it was something to work with. And we felt that it was valid because it wasn't as though we had asked the families about fractures and only the children who had fractures had emailed back. This was really a survey primarily for other purposes. And what the breakout showed was that about half of the kids were female and half male, and the mean age was about 10 years of age. We found that of those 42 surveys, 12 of the patients, so almost 30%, reported bone fractures. Again, an even distribution. It didn't seem to matter if you were a girl or a boy. And the mean age at fracture was quite young. It was 5 years of age, just like those two children I had initially seen. The total number of fractures in just those 12 patients was 27 fractures, and the average fractures per patient was 2, but we actually had some children with as many as 7 fractures, and I actually know in some of the children I've been referred, the most number of fractures I've ever had in a patient was in excess of 20 fractures. So the mechanism of fracture was very, very interesting, and I circled this because what we found was that most of these were atraumatic, which means that the child had no event that seemed to precipitate it. The mother would say he was standing in the kitchen and all of a sudden he fell, or he walked up the stairs and all of a sudden he was on the ground. Or something more subtle, I suddenly noticed that my child was limping. He wasn't complaining, he was just limping, and I wasn't sure what was going on, and after days I finally took him to the doctor, and this is what they found. So even more interestingly, the distribution of those fractures was very different than what we see in the healthy population. So kids are kids. They will go out and break bones. They climb on the jungle gym. They run and fall, often on an outstretched hand. And the distribution of fractures in healthy children is very well characterized. But what we see in our patients, rather than these outstretched hand type fractures, is actually a preponderance of fractures in the lower extremities. So 70% of the fractures were in the legs. Eight of the total fractures, or 30% of them, were in the femur, the top leg bone, and 11 were in the lower leg bones, either the tibia or the fibula. So what can we take away from this? We know that this survey suggests that children with Alagille syndrome are breaking bones without preceding trauma, that they are experiencing fractures at a younger age than healthy children. So what we generally see is more of the 10 to 11 age group. That varies with whether you're a boy or a girl, but in Alagille syndrome, it's at a much younger age, and that they tend to experience more fractures in the leg bones than healthy children. So we were always interested to quantify things, so we went to the literature and asked how many fractures are there in the healthy population, and there are reports of numbers of fractures in done by patient years, so per 10,000 patient years, and we tried to equate our population to those general numbers, and these are gross estimates. I think that this is kind of preliminary data in some ways, but what we found was that the total fracture incidence in Alagille syndrome patients was 400 out of 10,000 patient years versus 133 per 10,000 patient years in the healthy children. But if you look at the second line, it's even more impressive. There were 128 fractures per 10,000 patient years in the Alagille patients versus only 2.5 in the healthy population. So taken together, that's a threefold increase incidence in the Alagille syndrome patient for all-comer fractures, but a 50% or 50-time increase in incidence in the femur fractures. So why do children with Alagille syndrome have weak bones? I think there are a lot of reasons. One of them is probably poor intake. A lot of the children are not hungry. They don't seem to eat as well. There are things that we can do to address that. Some of the families have opted to use feeding tubes to help augment the child's appetite, and this can be extremely effective, not only in translating into improved growth, but also into improved bone health for the children. And I can tell you in my experience, most of those families were very reluctant to do that kind of feeding because it seemed unnatural to them, but yet when they saw the outcomes and how their children's overall development improved, they were very much in favor and recommended it to a lot of the other families. We also know that just malabsorption due to the liver disease, and some children actually have some effects in the pancreas, can cause deficiencies in absorption of calcium and fat-soluble vitamins, including vitamin D and K, which are critical for bone development. Kidney disease can also have its own effects on the bones. So if your child has intrinsic renal disease, that can also be impacting their bone health. And then finally, some children are exposed to different medicines for other reasons. So medicines like steroids, immunosuppressants used after transplant, and then cholestyramine can be a very useful drug for some purposes in terms of binding all those bile acids, but it also tends to bind up the fat-soluble vitamins like vitamin D, and so you need to really account for that and and help to make sure that the child's getting adequate vitamins. We also thought perhaps there were other reasons, because we have other children with severe liver disease who don't eat well and have all of those characteristics that I talked to you about on the previous slide, but yet they didn't seem to have the severity of presentation that we see in the Alagille syndrome population. So we postulated that perhaps there's something about bile acids or bilirubin that is almost toxic to the bones. I don't think anybody's really proven this, but it's a thought. Other thought would be, is there something about the change in the gene, the JAG1 mutation, that's actually affecting the developing bone, not just in terms of the anomalies that we see, like little butterfly vertebrae that really often have little to no consequence, but really affecting the intrinsic structure of the bone and perhaps making it even more vulnerable to these changes. So I think that there is evidence suggesting a gene effect. These are two papers that came out several years ago in Nature Medicine, which is really the be-all, end-all journal of at least of medicine, Nature and Nature Medicine. And these showed that Notch signaling, the Notch pathway where the JAG1 gene and the Notch2 gene lie, are actually important in regulating cell development within the bones. And some of my research in the lab, which some other folks have ongoing now, has looked at exploring the effects of that mutation in the developing bones. So we actually created a mouse. This is a skeleton of a tiny baby mouse embryo that's been stained. And you can actually use genetic techniques to just simply delete the JAG1 gene or change that gene in just one cell in the bones. And we did that, and we found that the regulation of the cell components were different in those bones than they were in other healthy mice. So exactly what that means, I'm not really sure, but I think that it suggests that your children may be at higher risk for bone problems than just simply the nutritional aspects lead us to believe. So what does that mean to all of you, and to what does it mean to your kids, and how can we protect them from bone fractures in the future? So I think that one thing is just being aware of the possible signs of fracture, and this seems simple, but a lot of the parents that came to me were horrified that their children had fractures. They never in their wildest imagination dreamed that they would have a fracture, and so they felt bad that they'd waited 2-3 days to take the child to the physician, and I think that's natural. I think that it's important to let families know that this can happen, so that if your child is complaining or limping or refusing to walk, that you know that this could be a problem. The other is to talk to your doctor about getting a DEXA scan on a pediatric scanner. The age of the child is usually about 4 or 5. Before that, they're a little too rambunctious to want to sit still in the scanner, but it's a fairly short procedure, and a 4 or 5-year-old can do this. I also suggest that families talk to their doctor about measuring vitamin and mineral levels. I usually do this every 3 months. As the child's growing very rapidly, it's important to keep up with their needs, and so even though you have a normal level one time, you may find that it's going to take you a lot of work to keep up with the child's growth requirements. I often will back off if I keep finding normal levels after a while, but some kids really constantly have abnormal levels, and you have to really chase those. I also suggest that you talk to your doctor about looking for kidney disease. We've had a lot of kids come to us where the physicians aren't aware of this phenomenon. It can affect the appetite, so if children have low bicarbonate levels, they often aren't hungry, and they may not have obvious signs of kidney disease. These are subtle findings on the labs that, if you're used to looking at this, that can be helpful. Encourage safe weight-bearing exercise. As I said, most people with 3-year-olds don't need to encourage that if their kids feel good. and then incorporating all of the sources of calcium and vitamin D. If your child is not growing well, I suggest getting a dietitian involved, because I think, especially in some of the major pediatric centers, these people who are trained to look at pediatric diets are excellent, and I've partnered with those folks in many of my patients and found tremendous help. Supplement vitamins as needed, and I always mention that your doctor can help you get insurance coverage. I think a lot of families get frustrated because the medicines are expensive and the insurance will cover rifampin, but they won't cover the vitamin E, but yet the vitamin E costs $100 a month. And so if your doctor can write a letter explaining the necessity of this for your child, which we actually have templated letters that I'd be happy to send you if you come and find me after the meeting, we can have you give that to your doctor, and they can write, sign the letter, and that can sometimes be helpful. And then finally, seek care of an experienced orthopedic doctor if your child does have fractures, because I think it's important for them to understand that your child may have some underlying metabolic bone issues that might make that treatment slightly different than it would if the child was a typical healthy child. I'd like to thank my colleagues at Children's Hospital. I also had some wonderful mentors at the University of Connecticut Children's Medical Center who were nice enough to let me come to their lab when I was a fellow and teach me some of their techniques, and I'm forever grateful to them. And also, in particular, the families that not only participated in our studies, but came to our center and really trusted us with their children. I'm very appreciative. Thank you.